Hi guys, if you're around, just give me a thumbs up so that I get to know I'm live. I'll also be trying to chase it from my device. So today we're going to spend around 1 hour time trying to learn some key essential details of neurology that are particularly important for the upcoming examinations. And I'm trying to keep it as simplistic and as high yield as possible so that we don't unnecessarily wander around with unwanted information. And hopefully at the end of this, you should be able to answer at least 70 to 80% of the questions that are going to come from these particular topics that we're going to discuss today. And before I start, let me tell you that at Unacademy right now, we are doing exciting things in the form of various tailor-made batches which are suitable for a particular examination. For example, this is the NEET PG 2022 batch, which is an all-educator revision batch, and in around 130 hours, we are trying to cover the essential aspects of the all 19 subjects, and this would be really useful for someone who is not well prepared as of now and he wants to make the most out of the remaining time that they have, right? So that is one thing. Then we also have this focus FMG batch which is going on as of now. So in around 2 months time, it is a relatively comprehensive batch, and it includes all the nation's top educators to cover the important topics for the upcoming FMG exam. And I would definitely recommend those who are preparing for FMG. In the past, we have achieved a great results. You can look at the results from our team. So it validates the Unacademy's approach towards the FMG preparation, and this batch would be something really great for those who are preparing for FMG. And having said that, let me also tell you that if you use this code doc medlive, right? If you use this code medlive, this might give you an awesome discount of 10% on any of your Unacademy subscription, including your iconic subscription. Okay, so now let me take you to the topic that I wanted to cover today. So that is movement disorders. Now when we talk about movement disorders, there are two possibilities. One, the movements are either increased, then we can call them as hyperkinetic, or the movements are decreased, then we call them as hypokinetic, right? So today's focus will be mainly on our hypokinetic movement disorders, but we have to also understand a little bit about the hyperkinetic movement disorders. So hyperkinetic movement disorders, where the increased movements are known, are further divided into jerky and non-jerky movements. So what are the examples of a jerky movement disorder? So what is the difference between the jerky and non-jerky? In jerky movements, there is varying acceleration of movements. So in non-jerky movements, there is a fixed tone and a fixed acceleration. So typical examples I can think of is your tremors and dystonia. Tremors have a fixed amplitude and a fixed frequency. There is no variation in acceleration. There is no variation in rate greatly as such. Yeah, physiological factors might increase or decrease, but at a given point of time, you probably see that the tremors are at a roughly narrow range of frequency, right? Similarly, dystonia, there is a sustained state of contraction, and that means again it is not going to be jerky, right? But if you look at the causes where there is a jerky movement, one thing is movements could be slow or fast, but there is varying degree of acceleration. Examples are your myoclonus, chorea, and tics. Tics could be verbal or motor. These are all hyperkinetic disorders. Now coming to hypokinetic disorders, the one main condition where we see akinetic rigid syndrome. Akinetic rigid syndrome. So as the name suggests, what do we see here? The name says akinetic rigid syndrome. That means there is akinesis plus rigidity, right? So reduced movements plus rigidity combined together, we get some set of disorders. We call them as akinetic rigid syndrome. So let us see what do we have in the akinetic rigid syndromes. The characteristic things, or the things that co-occur in akinetic rigid syndrome, are bradykinesia, hypokinesia, akinesia in their extent, and rigidity. When both combined, we call it as akinetic rigid syndrome. What are the classical examples? The classical examples of akinetic rigid syndrome are what we call as Parkinsonism. Right. So the Parkinsonism heading is a broad umbrella term. Akinetic rigid syndromes is a broad umbrella term. What comes under these are the specific things. For example, the idiopathic Parkinson's disease, or what we just simply call as Parkinson's disease, is just one of the cause for Parkinsonism. Right. So Parkinsonism is nothing but your akinetic rigid syndrome. So under this we have various headings: idiopathic Parkinson's disease, atypical Parkinson's disease. Some of these in the past used to be called as Parkinson's plus syndrome. So these are like Parkinsonism features plus additional manifestations. Apart from the akinesis and rigidity that we are talking about, the two standard components, they have additional manifestations like the dementia, other abnormalities. So we used to also call these as Parkinson's plus syndromes in the past. Okay, but this is the naming convention mostly followed today. Idiopathic Parkinson's disease, atypical Parkinson's disease, secondary Parkinson's disease. What are secondary Parkinson's disease? Which are not directly due to inherent degenerative changes, but something else is causing the defects. For example, your vascular injuries, infections, toxins, metabolic, NPH, and autoimmune disorders. Right? So these are called as, if you are seeing akinetic rigid syndrome due to any of these causes, you will call them as secondary Parkinson's disease. The last one group is called as hereditary or degenerative, or in other words, you can call them as heredodegenerative. The classical examples are Huntington's disease, Wilson's disease, and Halloward-Spatz disease. This HSD stands for Halloward-Spatz disease. On the MRI, you see this. I think only one point I want you to remember. On the MRI, you see something called as eye of the tiger appearance, right? So we will discuss that when we discuss the image-based questions. This broad classification is clear. Now, what is the main difference between the so-called idiopathic Parkinson's disease and everything else? What is the main difference? So I said Parkinsonism is roughly equivalent to akinetic rigid syndrome. So we are seeing the standard two components, bradykinesia plus what else we are seeing? Bradykinesia plus rigidity, right? Let us see what are those rigidity manifestations in bradykinesia later, but right now understand, whenever we say akinetic rigid syndrome, or in simple words, whenever we say Parkinsonism, we are talking about a combination of these two, bradykinesia plus rigidity. So that will definitely be there in a patient with Parkinson's disease, right? So there will be bradykinesia, there will be rigidity. But if you remember, mostly you recognize Parkinson's disease for tremors, right? Mostly you recognize it for tremors. So that is an addition in patients with Parkinson's disease, which are usually uncommon or rare in all other entities. You might see rarely, but these are usually rare. So when you have tremors, the classical Parkinson's disease tremors, you're probably dealing with a case of idiopathic Parkinson's disease. In case of atypical Parkinsonism like PSP, CBD, MSA, or DLB, tremors are rare. Okay. Same with respect to most of the secondary Parkinson's disease or secondary Parkinsonism, like for example vascular infections, metabolic, NPH, autoimmune. Tremors are rare. Okay. Sometimes the drug-induced Parkinsonism might manifest with tremors. Drug-induced may have tremors. So this is one exception I want you to remember. Drug-induced may have tremors. Okay. Again, hereditary degenerative, Huntington's, Wilson's, HSD, you don't recognize them for tremors, right? Not associated with tremors. So the message is loud and clear. What is the main differentiating feature between the idiopathic Parkinson's disease and the other conditions which are known as Parkinsonism, including atypical Parkinson's, secondary Parkinson's, and heredodegenerative Parkinson's? Tremors, right? So tremors are very classical of idiopathic Parkinson's disease, and tremors are relatively rare with respect to all other movement disorders. Okay, so is that clear? Yeah, only other thing I would think of when the tremors comes into my mind is probably drug-induced Parkinson's disease, right? Okay, now having said that and having understood the classification, let us also look at one more classification of akinetic rigid syndrome, which is more of a clinical classification. So whatever I said so far, it is more of a etiological classification, right? So now let us look at the clinical classification. Clinical classification of the akinetic rigid syndrome or Parkinsonism goes like this. We can classify them as tremor predominant, which is the most common type and which is nothing but our idiopathic Parkinson's disease. So 80% patients of idiopathic Parkinson's disease have tremors at the time of presentation. At the time of first diagnosis, 80% have tremors. Another 20% may not have. Some of them will eventually manifest. Some of them may not develop tremors. But if you have tremors, it is very certain that it is most likely a idiopathic Parkinson's disease rather than anything else. Okay, that is one phenotype. So we call them as tremor predominant phenotype. And whenever there is a tremor predominant phenotype, the first thing that should come to our mind is idiopathic Parkinson's disease. Okay, the second set is when you have akineto-rigid phenotype. Akineto-rigid phenotype is where you only see rigidity and bradykinesia. That is the second set. So most of your atypical will fall into this picture. Most of the atypical Parkinsonism, with some exceptions. Okay, so the third phenotype is where you have a postural instability gait disorder. Means it is a movement disorder. hypokinetic movement disorder that we are talking about, where patient most likely present with frequent falls. So they have postural instability as their main component, as their main complaint. What is the example? The progressive supranuclear palsy is one. Then sometimes the MSA C type, multisystem atrophy C type. These can present with your postural instability gait disorders. Right? Otherwise, for all other Parkinsonism conditions, including secondary drug-induced, right, you have to think of this rigidity bradykinesia phenotype. That means patient is having bradykinesia and rigidity, and the clinical manifestations arising out of this rigidity and bradykinesia. Right? Okay, so at least this much is now clear. Tremors should go in favor of the Parkinson's disease. Absence of tremors, having rigidity and bradykinesia, it is probably the other causes of Parkinsonism that we are talking about. Okay, now having said that, let us look at the first distance disease. So what all we know so far, idiopathic Parkinson's disease is where we will have bradykinesia, right? We will have bradykinesia, plus what we will have? We will have rigidity, plus what else we will have? Plus we will have the tremors. So the tremors are the differentiating feature here, right? We will have tremors. So we will understand all these clinical features one by one, but before that, just take a little quick look at the epidemiology. The idiopathic Parkinson's disease is the second most common neurodegenerative disorder. This is one MCQ point. They might ask you what is the first most, or they might ask you what is the second most. So the first most common neurodegenerative disorder is, anybody has an answer? The first most common neurodegenerative disorders is Alzheimer's disease. Alzheimer's is the first most common neurodegenerative disorder, followed by Parkinson's disease. And Parkinson's disease affects males more than females. And the usual age of presentation is late. It is not an early disorder, right? So age and family is definite well-known risk factors. The usual age of presentation is usually 6th decade onwards. The age of presentation is usually 6th decade onwards. So at 40, 50, you generally don't think of diagnosis of Parkinson's disease. If you're seeing someone with Parkinsonism, probably you're dealing with an atypical. If it is like 40 or 50, it's usually 67, 6th decade, 7th decade onwards is what you start seeing these patients presenting with the defects. Okay, so age is a risk factor, right? And also family history can be a risk factor, because we know certain inherited forms of Parkinson's disease where a single gene mutation may be associated with the Parkinsonism. Now, it will be too much of a stretch for us to discuss about all these genetic mutations, but I will give you a quick review of the points that you should remember. What are those mutations which are associated with the late onset Parkinsonism? Means you have this gene, but the diagnosis is usually at the regular age of the diagnosis of Parkinson's disease, not early. Right? So for that, examples are your PARK1 mutation, PARK4 mutation, 8 and 5. Right? 1, 4, 8 and 5. These are the ones which are associated with the late onset Parkinsonism. Means patient is presenting in roughly 7th decade only. The usual age of presentation of Parkinson's disease, not before that. Right? But PARK2, 6 and 7. This, if you remember, I think that's kind of more than enough. 2, 6 and 7, these patients are presenting with early onset Parkinsonism, because if you have these mutations, you might develop Parkinson's disease and the onset may be early. If you remember about the genetics this much, I think that is right now kind of adequate. Okay, so now that brings me to the pathology. Let me see if there are any pending questions. Okay, so coming to the pathology, what is the abnormality in patients with Parkinson's disease? As we all know, it is a neurodegenerative disorder, right? Neurodegenerative disorder. So where is the degeneration occurring? The degeneration is occurring in the dopaminergic neuron, right? Neurodegenerative affecting the dopaminergic neurons. Dopaminergic neurons, right? So because the dopaminergic neurons are getting lost or degenerated, whatever function that particular structure was supposed to regulate is impaired, and that is why we are getting this bradykinesia and rigidity plus tremors in Parkinson's disease, right? Now the first question is, what is the site where the first evidence of the neurodegeneration becomes evident? Which structure is primarily affected in patients with Parkinson's disease, and what is the structure where you will see the earliest evidence of neurodegeneration, right? So this is one important MCQ point. Earliest site to show degeneration in patients with Parkinson's disease. Anybody has any thought on this? Which is the earliest site where you will see the degenerative evidence? Okay, so well, you have to remember that In Parkinson's disease, typically we are talking about substantia nigra, which is the typical site of degeneration, substantia nigra and nigrostriatal pathway. Right, this is the site of degeneration, but this is not the earliest site. So in Parkinson's disease, we are not only talking about bradykinesia, rigidity and tremors. You might have the extra motor manifestations, right? So those are also important. Like some patients of Parkinson's disease might develop dementia, some patients of Parkinson's disease might have various other clinical presentations, right? I'm not talking about plus syndrome here. Parkinson's disease itself can have the manifestations beyond these three classical things: bradykinesia, rigidity and tremors. For example, dementia. Anosmia, you may be familiar with. Some patients have anosmia. Some patients have autonomic disturbance, right? Autonomic disturbance. So all of these are the extra motor manifestations of a Parkinson's disease. So that means it is not only the degeneration is not only restricted to the substantia nigra or the nigrostriatal pathway. Degeneration can occur beyond that. In fact, in pathology, you get a staging system called as Braak staging system. So this Braak staging system actually looks at the sites of neurodegeneration. Obviously, this is a histopath based, and for this you need a brain biopsy, but at least having looked at various cases and histopath specimens, we know how the Parkinson's disease progresses. The site where we will have the earliest evidence of loss of neurons, dopaminergic neurons, and what is the second site, what is the third site, what is the fourth site. So we call this as Braak staging. So let me take you through this Braak staging once. Okay, so Braak stage is now currently divided into 6, but the original Braak was into 5 stages. Okay, so in stage 1, the earliest site where you will see neurodegeneration of dopaminergic neurons is not your substantia nigra. So much before that, you will see the degenerative changes occurring in the anterior olfactory nucleus, and raphe nucleus of cellulose. Okay, so because of the changes in these locations, what is the concern? These locations are supposed to be concerned with osmia or your smell perception. So if you have loss of anterior olfactory nuclei function, what you will get? You will get anosmia, right? The second thing is your raphe nucleus of cellulose is concerned with autonomic disturbance. So if you have abnormalities of that, then you will get autonomic dysfunction, right? So in stage 1, stage 1 and 2 combined, you will see autonomic dysfunction and olfactory disturbances. So you have to remember one point here. Much before patients start showing the motor manifestation, the tremors and the bradykinesia and the rigidity, all are motor manifestations, right? So many years before patients starts noticing the motor manifestations, they might have anosmia. Anosmia often predates or exists for many years before patient develop motor manifestations. Then why don't we diagnose them at the stage of anosmia? Probably because of the low threshold, like very high threshold for reporting. So they don't come to hospital because my smell is slightly decreased, right? So only when they start noticing tremor or the bradykinesia, they are coming to the hospital. So that is the reason why at the time of diagnosis, most patients have tremors. Okay, that is one. Then this autonomic disturbance, how does it manifest? This autonomic disturbance might manifest in the form of erectile dysfunction. That could be one of the early clue, erectile dysfunction. So some of these patients may get diagnosed as Parkinson's disease eventually, who are now being evaluated or being treated for erectile dysfunction. Okay, only when the motor manifestations are evident, we become more confident about the diagnosis of Parkinson's disease, right? Similarly, this can cause resting tachycardia, which is one more manifestation of autonomic disturbance. And unlike the autonomic disturbance or autonomic function that we see in diabetes mellitus, here you might see these patients presenting with constipation. So autonomic disturbance can cause both constipation and diarrhea. So in diabetic autonomic neuropathy, we see diarrhea predominance. Here we see constipation, which is one of the bothersome symptom or the complaint that these patients often come back to hospital, right? So biggest sign of the loss of neurological neurodegeneration or loss of dopaminergic neurons is seen in mainly the anterior olfactory nuclei, right? So that is why anosmia is a complaint which exists many years before the onset of motor manifestation. So motor manifestations usually become evident. Motor manifestations become evident in stage 3 of Braak. This is one important MCQ point. Stage 3 of Braak is where you will start seeing motor disturbances. Right. So what is happening in stage 3? The stage 3, the neurodegeneration from the anterior olfactory nucleus is now also shifted to your substantia nigra. Right. Substantia nigra starts showing evidence of neurodegeneration in stage 3. Right. So because of that, these patients start presenting with the bradykinesia, rigidity, tremor. So the earliest evidence of motor dysfunction is evident in stage 3, where there is neurodegeneration in substantia nigra. So this is one more MCQ point, right? Okay. So where is the earliest evidence of neurodegeneration? That is in the anterior olfactory nucleus and the locus coeruleus. So because of that, patients might have anosmia and your autonomic disturbance. Then you will start seeing the degenerative changes in the substantia nigra, that is stage 3. At this point of time, patient might present with the motor features, right? Okay. Moving forward from this substantia nigra, later you will start seeing evidence of the more extensive neurodegeneration, right? So mainly the one that is affecting the cortex. So once the cortex starts getting affected, the involvement of cortex is typical of your stage 5. Stage 5, the cortex starts getting involved. So at this point of time, you might start seeing the dementia or cognitive dysfunction. So dementia, is it part of Parkinson's disease? Yes, it is part of Parkinson's disease. Is it a early manifestation? Absolutely no. From stage 4 to stage 5, there is almost a decade time. So if you have a patient of Parkinson's disease who is diagnosed with the motor features in 6th decade, maybe in 7th decade he might satisfy the criteria to be called as dementia. Now what is dementia? The dementia is where you have cognitive dysfunction which can be assessed by your mini mental status examination, and a low score would mean that patient has cognitive dysfunction. Plus this cognitive dysfunction is leading to impaired activities of daily living. Right? In other words, patient has some cognitive decline and that is affecting their day-to-day activities, impaired activity of daily living. Then we will call it as dementia, right? So the dementia is a very late manifestation. Why am I stressing on this point? Because we also hear one more term called as diffuse Lewy body dementia or dementia with Lewy bodies, right? What is the difference between dementia with Lewy bodies and Parkinson's disease? We are seeing, so that is also a condition. DLB is also a condition where you will see patients presenting with bradykinesia and rigidity. Parkinson's disease is also a condition where you will see patients presenting with bradykinesia and rigidity. Tremors are also relatively common in both these conditions. So what is the difference? The difference between DLB with DLB dementia and the Parkinson's disease is that the dementia is a late manifestation of Parkinson's disease. So 80% of the patients at the time of presentation, they have movement abnormalities, that is your bradykinesia, rigidity and tremors, right? And many years, roughly a decade later, they might develop dementia if it is a case of Parkinson's disease. In dementia with Lewy bodies, usually dementia occurs along with motor features. So at the time of presentation, patient might have dementia and motor features, or dementia may predate. So what do I mean by that? First you will diagnose the patient as having dementia, and then later you diagnose that, later they start showing the motor features. So initial diagnosis dementia, years later they start showing motor features, or at the time of presentation they have both. In Parkinson's disease, usually they only have motor features, and later on, almost a decade later, they present with dementia, right? In DLB, at the time of presentation itself, they have the dementia plus motor features, or they are diagnosed at the dementia stage and later they develop motor features. It is ulta in case of Parkinson's disease. Or the third possibility is motor features may occur first. Motor features will be followed by dementia, but the latency period is very short, usually less than 1 year. Within 1 year of patient being diagnosed with motor manifestations, he will have the dementia also being diagnosed within 1 year. In case of dementia with Lewy bodies. In case of Parkinson's disease, it is almost a decade latency. Right, it's a slow progressing entity. It's almost a decade latency. So here it is less than 1 year. So today you're diagnosing someone as you think it is Parkinson's disease because patient is having motor features, and within 1 year he satisfies the criteria to be diagnosed as dementia. Then again it is likely to be DLB rather than Parkinson's disease, because if it was a Parkinson's disease, you will diagnose him as dementia after the onset of motor features, maybe roughly 10 years down the line or much more later, right? Okay, so this is one point you have to remember, the difference between idiopathic Parkinson's disease and dementia with Lewy bodies. Before moving on, what do we call this as? We call this staging system as Braak staging. This is primarily a pathological staging, but now we have started using this in radiology. Means because we could see these degenerative changes in different parts of the brain, we can also interpolate or extrapolate this information to do a radiological staging. Is it very relevant right now? No. The only thing I have included this is I want you to be aware that anosmia and autonomic features usually predate for many years before the patient develops motor features, because the earliest site of neurodegeneration is not your substantia nigra, but it is your anterior olfactory nucleus and locus coeruleus. After that, you see the degenerative changes in the substantia nigra, and later on you see the degenerative changes in the cortex. So once you start seeing the degenerative changes in the cortex, you start developing dementia. That is why dementia is a late manifestation of Parkinson's disease. Okay, so if that is clear, let us look at the clinical features of Parkinson's disease. The clinical features we have to assess in terms of the onset, what are the motor features and what are the non-motor features we see, right? So what are the motor features that we see in patients with the Parkinson's disease? Okay, anybody wants to answer? It is not always genetic. It is not always genetic. So we have identified a plenty of genes, like 30 plus genes now, but there are still they account for only less than 10% of the case. So in remaining percent of patients, we don't know what is the etiology. Okay, so now moving on, I was talking about the motor and non-motor features. So what are the motor features? We will be seeing features because of bradykinesia and features because of rigidity and tremor. So let us see one of each of them one by one. Like, so let us start with the tremor first. What we should remember about tremors? The first point we have to remember about the Parkinson's disease tremors is it is a rest tremor, right? So we describe it as rest tremor. That means when the limb is at rest, you will see the tremors. Movement might abolish the tremors. We are trying to differentiate it from another set of tremors called as intention tremors, which are characteristically seen in patients with cerebellar lesions. So in intention tremor, when you try to move and when you try to achieve some target, there is tremor trigger. That's very typical of cerebellar disorder. So here it is rest tremors. The tremors are present at rest. What other examples you can think of rest tremors? Your essential tremors, the tremors that you see in patients with hyperthyroidism. These are all rest tremors. They are present at rest. They may get abolished by movement, or sometimes the movement might even exaggerate in some types of rest tremors, but they're certainly present at rest. They are not brought about by movement, like as in case of cerebellar tremors. Cerebellar tremors are typically brought about by movement. They are not there at rest. You start moving, they become evident, right? Okay, so these are rest tremors. What is the frequency? We should always remember at least some important disorders, the frequency of tremors, because again, if the frequency is high, the tremors are going to be fine and the amplitude of the tremor will be less, like the movement will be less if the frequency is high. If the frequency is low, the amplitude will be slightly better or slightly higher, so it will be easy to perceive visually when the tremor has low frequency, high amplitude. If the tremor has high frequency and low amplitude, it is difficult to appreciate from bare eyes. For example, hyperthyroidism, you usually put a piece of paper on their hand and try to see it, because it is difficult to appreciate that tremor from bare eyes because they're very fine. When I say fine, what does that mean? That means the frequency is high, amplitude is low. So the movement range is not high like this. They're moving very subtly, so it is difficult to appreciate from bare eyes. So in Parkinson's disease, the frequency of the tremor is usually 4 to 6 hertz. 4 to 6 hertz. So that's not very fine tremor. This is something that 4 to 6 hertz means in 1 second the tremor is occurring 4 to 6 times. So it is easily appreciable from bare eyes. It is not a very fine tremor in comparison to essential tremor and the tremor that you see following hyperthyroidism. Those are very fine tremors. So essential tremor usually, that is one point we have to differentiate. The frequency is 8 to 14 hertz in case of essential tremor. Right? In case of Parkinson's disease, it's 4 to 6 hertz. Okay. What is the characteristic nature of the tremor and which parts of the body are affected? We describe this characteristically as your pill rolling tremor. Pill rolling nature of the tremor. So you all are already familiar with the pill rolling nature of the tremor. So I don't need to really describe more about that. But there are some points you have to remember. Parkinson's disease usually at the time of onset is asymmetrical. Asymmetrical. So asymmetry is the norm, asymmetry is the rule in case of Parkinson's disease. because if you remember, we were talking about this Bragg staging. So the neurodegeneration probably starts in one side of your brain, and then eventually it will get involved the other side. So because the neurodegeneration is progressing in a temporal fashion, there will always be asymmetry maintained. Like first, you are seeing tremors in the right hand. Eventually, yes, it might become bilateral. You will start seeing tremors in the left hand also. But because the neurodegeneration first started on your right side, right, on your the regulation of the right side movements, you will see that it will be further progress. By the time the left side get involved, the right side would have become much more severe, right? So there is always an asymmetry. So if you look closely and examine the patients closely, you will notice that until quite late in the disease process, there is no symmetry. Bilaterality, yes, acceptable. To start with, it is unilateral. It will eventually become bilateral. But even when it is bilateral, the severity is not same on both extremities. There is some degree of asymmetry which you can easily appreciate if you look closely. If you have an eye for it, you will be able to appreciate that the tremors are not so severe in one limb in comparison to the other limb. So this is one point I want you to remember. Why I want you to remember? Because this helps us to differentiate this from various other tremor disorder. For example, essential tremors, it is bilateral but very symmetrical, right? That is one point. Second, you know this drug induced Parkinsonism, mainly these dopamine receptor blockers, drug induced Parkinsonism, mostly caused by psychiatric medications, dopamine receptor blockers. There it is usually symmetrical. So far we have only discussed three conditions where there is akinetic rigid syndrome plus tremors. What are those? The number one was our Parkinson's disease. The number two was the dementia with Lewy bodies, where I said that tremors might occur before, along with, or later. The dementia would be the dominant feature, but tremors can be seen. And the third thing is drug-induced Parkinsonism. So in drug-induced Parkinsonism, because you are giving a drug which cannot differentiate between your right and left of the brain, right, it will affect this dopamine receptors equally on both the sides. So the tremors are going to be symmetrical. In drug-induced Parkinsonism, the tremors, if they are present, they are seen in 2/3 of the patient. They will be symmetrical. In patients with Parkinson's disease, till quite late in the disease progress, often it is unilateral, or if it is bilateral, it is going to remain asymmetrical. Right? So this is one particularly important point that will help you to distinguish between your drug-induced and your IPD. Right? Okay. Then there is also something called as re-emergent tremor. Anybody is aware of what is the re-emergent tremor? Re-emergent tremor, which is very characteristic of Parkinson's disease. So I have already told you that the tremor in Parkinson's disease is rest tremor, right? So usually when you put the limb in motion, the tremor usually disappears. So I am having pill rolling tremor. You ask me to pick up a pen. When I pick up a pen, when my hand moves to pick up the pen, the tremor disappears. I'll be able to pick up. Okay. So the movement usually abolishes this tremor. Okay, but after I have started moving, my limb comes to rest, right? Limb comes to rest. Now we are expecting that the tremor should reappear. That is that because it's a rest tremor, but it is not going to reappear immediately. There will be some time lag of around few seconds of time lag, and then the tremor becomes evident. That is what we call as re-emergent tremor. So you had tremor, you started movement, tremor disappeared, you brought the limb to rest. After the limb has been brought to rest, the tremors are not immediately evident. It takes few seconds time, this latency, and then the tremor reappears. This is what is called as re-emergent tremor, which is very characteristic of Parkinson's disease. You don't see it in drug-induced Parkinsonism, or you don't see it in any other tremor disorders. It is very characteristic of Parkinson's disease, right? So this is one particular point I want you to remember, what we call as re-emergent tremor. Okay, so these are the important points we need to know about tremors. It is rest tremor with a frequency of 4 to 6 Hz. It's characteristically described as pill rolling. It is usually asymmetrical. This is the most important point to note. And the second most important point to note is we have something called as re-emergent tremor, which is very characteristic of idiopathic Parkinson's disease. Okay, so is that clear? Now, the second set of motor features are related to bradykinesia. Now, basically speaking, what is bradykinesia? There is slowness of movement, right? Slowing of movements. And it can lead to various other manifestations. We will discuss about that. But then slowness of movements can also be seen in various conditions. For example, a patient with depression or schizophrenia, or patients with hypothyroidism, they might have bradykinesia. So bradykinesia is not specific to akinetic rigid syndromes, right? So bradykinesia is not specific. You can see it in non-degenerative conditions like hypothyroidism. You might see bradykinesia. Patients with major depression, you might see like they're not moving about. Patients with major depression, right? Then you might see bradykinesia in patients with schizophrenia. So how do you differentiate bradykinesia from all these conditions? Okay, if tremor is present, then like the differential diagnosis is quite narrowed down. But if the tremor is not present, how do you differentiate? Okay, so you should be aware about something called as finger tap test. This is one simple bedside test that can help us to distinguish between the bradykinesia due to your Parkinson's disease and the bradykinesia due to other non-movement disorder conditions like hypothyroidism or the psychiatric diseases. So if you ask the patient to have his finger outstretched like this and keep tapping till you say stop, when a patient with the normal person will have, you should tell them that tap as fast as possible and as wide as possible, like as fast as possible, as wide as possible. This is what we call as finger tap test. Your thumb and your index finger tap as wide as possible, as fast as possible. In a normal person, they will be able to do that, like I'm doing it at my best possible space. Now those who have bradykinesia, obviously there will be slowness of movement. I'm not worried about the rate in those patients who have bradykinesia. What I'm concerned about is the amplitude of this movement. So normally patients with Parkinson's disease, they start wide, and as they continue to move more or continue to do this activity, the amplitude keeps declining. So they start wide, slow, obviously slow because bradykinesia is there, starting wide, slowly the amplitude keeps declining. That is what is very characteristic of Parkinson's disease. So in other conditions like hypothyroidism or depression, those patients, they will move slow, but their amplitude is unaffected. You're getting my point? So in Parkinson's disease, they're starting wide, but their amplitude keeps declining. So this broad to this broad to this broad to this broad to this slow. In other conditions, they are slow, but the amplitude remains unaffected. So if you ask a depressed person like do this, okay, ठीक है, चलेगा, करता रहूँगा, right? So that is a simple bedside test that helps us to distinguish. And remember, if you ask the patient with Parkinson's disease, you ask them to write. How do they write? They write with something called as micrographia, right? We see this micrographia. Now, what do you mean by micrographia? Their handwriting is very tiny. Like our teachers used to call some students' handwriting as ant's leg appearance. Yeah, so it is very tiny. But even in that tininess, if you ask them to start write, you will notice that they start little big, and as they keep writing, it becomes smaller and smaller. So you can correlate this finger tap test. The amplitude kept decreasing. The same thing you can also see when you ask them to write. So they start with a wider letter, and then as they keep writing, it becomes smaller, smaller, smaller. Micrographia true, but the micrographia also, to start with, it was much more larger, and it becomes much more smaller as the writing progresses. So similar thing we are seeing in this finger tap test. So finger tap test can help us to distinguish between the bradykinesia of the psychiatric origin or your other systemic disorder related and the bradykinesia due to movement disorder, which is nothing but Parkinson's disease. Now, apart from this bradykinesia, we also see something called as hypomia, or you call it as mask-like faces. Right? Why are we seeing this? So in patients with Parkinson's disease, there is usually reduced expressions. Why this reduced expression? The reduced expressions are because of your bradykinesia itself. So you hear something, at least in the early phases, it is because of bradykinesia. Right? So I'm a patient with Parkinson's disease, you tell something to me, either exciting or depressing or a very short news or a shocking news. Right? I might perceive it, I might understand what you're saying. My neurologically or my thought process has understood what you've told. I'm shocked, I'm excited, but because there is slowness of movement, right? My facial expression movements are also very slow. So for you, it is as if that I did not have an expression or I did not have emotions. In fact, patients with Parkinson's disease have much more increased emotional ability, but it doesn't show up on their face because of the slowness of their movements. So facial movements are also slow. That is why we don't see the emotion and the shock news correlate, right? So that is one thing. Hypomia, which is nothing but expressionless or mask-like faces. Expressionless or mask-like face. Okay. Then we see hypophonia. Hypophonia in the sense there is shrill low tone voice, right? So decreased amplitude and the intensity of the voice. Micrographia I have already discussed. So these are all typical manifestations of bradykinesia. Okay. Now looking at what rigidity causes to a patient with Parkinson's disease. Okay. What rigidity causes? The rigidity typically manifests in the form of either cogwheel, most likely cogwheel rigidity, and the second thing we will be talking about is something called as camptocormia. But before I take you there, we should understand what is rigidity, and you should also understand what is your bradykinesia. So anybody knows, not bradykinesia, what you call as spasticity. What is the difference between rigidity and spasticity? What is the difference between rigidity and spasticity? Okay, so typically the rigidity is where you have a sustained state of contraction throughout the range of movement. So the first of all is the rigidity and spasticity are manifestations of hypertonia, right? So what is the tone of a muscle? That is the basic understanding we need to have. The tone of a muscle is the resistance offered to passive movement of the muscle, at passive movement across a joint. For example, if I have to understand the tone of my flexors of the upper extremity, I have to flex my upper extremity. Flex. If I have to assess the tone of the flexors of my arm, then I have to flex my arm passively. Like examiner has to flex, and whatever resistance he encounters, that is the tone. Right? If it is increased hypertonia, if there is no resistance encountered at all, absolutely limp, then it is hypotonia. Right? So in hypertonia, if it is velocity dependent, that means initially there was too much of resistance, but as he accelerates, the resistance is lost. That is very typical of spasticity. It's a velocity dependent. So in rigidity, that it is not velocity dependent. Right? It is throughout the range of movement. Right? Initially in spasticity, as you start moving them, you will experience more rigidity or more resistance, and as you go away, there is a giving away of the resistance. That is typical of spasticity. So in rigidity, throughout the range of movement, you will have a similar range of resistance offered. So that is what one thing we call as lead pipe. Now what is cogwheel? A cogwheel is where superimposed on the rigidity you have the tremor. So because there are tremors, you will not experience the resistance to be smooth. It will be jittery like this because there are ongoing tremors of the limb, right? So you are experiencing resistance, but it is superimposed by tremor, so it will be jittery. That is what we call as cogwheel. So characteristically in patients with Parkinson's disease, we are expected to see the cogwheel type of rigidity. Okay, so that is one manifestation. But before we understand the next manifestation, we have to also remember that we have to differentiate Parkinson's plus syndromes or those atypical Parkinson's disease from the Parkinson's disease in terms of rigidity. Rigidity in both these set of disorders is not exactly same. The rigidity in Parkinson's disease is subtly different. What is the difference? One, it is cogwheel because there are tremors. In other conditions, tremors are not usually seen, so it is going to be lead pipe type, right? Early stages when tremors are not severe, you might experience lead pipe, but characteristic the rigidity is cogwheel. The second thing I want you to note is the rigidity in patients with Parkinson's disease usually affects both your axial, extra-axial skeletal. That means the muscles around your vertebral column, your spine, right? The center part of your body, those muscles are affected with rigidity. Similarly, your extra-axial means your extremity muscles are also affected with rigidity. In most of the atypical Parkinson's disease patients, the rigidity predominantly affects the axial skeleton and the extra-axial is usually spared. 1 point, clear? So here you will see rigidity of your extremities, here you will see rigidity of your the spinal muscles. In case of atypical, you will only see the rigidity of your axial skeleton, your limb muscles are not showing the rigidity that much. Okay. This is 1 point clear. The second point is the rigidity in patients with Parkinson's disease is more on the anterior group of your axial muscles in comparison to posterior group. In most other cases of atypical, it is the posterior group of muscles which are more affected than your anterior group of muscles. Now, when there is more rigidity of the anterior group of muscles, what happens? Your muscles on your abdomen, mainly the abdominal muscles, they contract. So that gives you a stooped posture like you're seeing in this case, because the rigidity is more on the anterior side muscles. So those are in more sustained state of contraction in comparison to your posterior muscles. Now this erect posture is a fine balance between the tone of your anterior muscles and the posterior muscles. Once differential tone occurs, one side is hypertonic in comparison to other, then obviously that side the body starts tilting. So because it is anterior group of muscles more affected, the body is assuming a stooped posture. So this stooped posture gives rise to the gait abnormalities that we will be talking next. This point is clear. The stooped posture is mainly because of the hypertonia of the anterior group of axial muscles. Okay, so this stooped posture is also called as bent spine syndrome, BSS. Okay, but this is not your spine deformity. The stooped posture is not because the spine has been deformed, like in your case of kyphosis or scoliosis. The spine is not deformed. So this deformity disappears the moment patient is made to lie down flat on a surface. Right? So when they are erect, standing or sitting, because of the gravity and your increased tone of the anterior muscles, they are in a flexed position. They're stooping forward. The moment you ask them to lie down flat, right? The moment you ask them to lie down flat, like you see in this image, this bent spine disappears. So it is because of the muscles abnormalities and not because of the deformity of the spine, right? So this phenomenon is what is called as camptocormia. A bent spine which disappears on lying flat is what is called as camptocormia, which is seen in patients with Parkinson's disease, and sometimes, rarely, it can be seen in patients with old age. Elderly, you might see it. So these are the two conditions that should come to your mind whenever you see camptocormia. Clear? Now I told you that this rigidity leads to something called as stooping forward or stooped posture. Now when the patient assumes this stooped posture, his center of gravity is shifted forward, right? His center of gravity is shifted forward, and that leads to some of the characteristic gait abnormality we will see in these patients. What is the gait abnormality? You generally describe the gait in a patient with Parkinson's disease as short, shuffling, festinant gait. Right? This is a typical description. Short, shuffling, festinant gait. So what is happening? So patients with Parkinson's disease, first of all, they have the bradykinesia. So they have difficult. Usually when we describe the gait, we should start by, so you can start from a patient who is sitting in chair. He gets up, moves about, turns, comes back, and sits in the same chair. That completes the assessment of the gait in a patient. So these patients of Parkinson's disease, they have, first of all, movement abnormalities. I mean, they have this bradykinesia. So there is slowness of initiation. So they have initially difficulty in getting up, right? Somehow they will slowly get up from their sitting posture and they make a erect posture, right? So in the erect posture, the next thing we talk about in the gait is the base. Base is nothing but your gap between your 2 feet. That is the base. So you often describe it as wide base, narrow base. So in patients with Parkinson's disease, it is either normal gait, normal base, or narrow. It is not wide. Okay, again, this is one point which will help you to distinguish some other Parkinson plus syndrome as we go along, right? So remember here, the base is usually normal or narrow, not wide. So their 2 feet are not like they're standing apart as if they're peeing. They're standing normally or little close. And once they stand, they start taking their steps. So the steps are small and the steps are shuffling like this. That's why we describe it as short shuffling steps. Instead of taking normal distance steps, they're taking steps which are short and they're shuffling like this. So that's why we call it as short shuffling gait. Now what is festinant gait? These patients already have a stooped posture. So they are like, they got up slow. They somehow stood in a normal base or a narrow base. They started taking their first steps. They're taking short steps and they're shuffling their steps. And as they start moving forward, because they have this stooped posture and their center of gravity is anterior, much more forward, right? They have a tendency to fall forward as they start walking. And to compensate from falling, what they do is they start accelerating more. So as they feel that they're about to fall, the gait becomes accelerated. That is what exactly we call as festinant gait. So this acceleration to escape fall because of that anteriorly shifted center of gravity is what we call as festinant gait, right? So this is how we will see. So initially, in the initial few years of life, they will be able to compensate this chance of falling by accelerating whenever the fall tendency occurs. But eventually they will start falling. So falls are a frequent complication of patients with Parkinson's disease. Okay, clear? So that was about the rigidity and gait. So we have learned about the tremors, we have learned about rigidity and bradykinesia. Okay, now before I move on, I want to introduce one more term called bradyphrenia. Anybody is aware of what is this? Bradyphrenia. Bradyphrenia. YC, yes, you're partially correct. Yes. So in Parkinson's disease, yes, I missed to tell you one point. The involvement is more predominant on the upper limb in comparison to lower limb. So because the involvement is more predominant in terms of tremors, the upper limb tremors are more severe, So because of that, the lead pipe is the baseline abnormality. When you have the rigidity, the lead pipe is the baseline abnormality. But because there is tremor which is more predominant in the upper limb, you will see that the upper limb will have this characteristic cogwheel, and the lower limb tremors are quite late manifestation, and they're not so severe as compared to upper limb. So most likely you will have that lead pipe type of rigidity. Yes, you're right. You're right. Okay. Anybody is aware of what is this called bradyphrenia? Okay, just like how you have bradykinesia, slowness of movements, you have bradyphrenia, which is nothing but slowness of thought process. So that is also seen, not an early manifestation. As I've already told you, the degenerative changes of the neurons of the cortex occur in stage 4 and stage 5, stage 5 almost of the Bragg staging. So it's a late presentation. So you might have slowness of thought process also in patients with the bradyphrenia, and that is where you characteristically start seeing this mask-like faces. So you tell something to them, hyper exciting news or a saddening news, the processing itself is taking some time. And once the processing takes some time, once a patient has understood what you meant when you declared the news to them, after that there is bradykinesia. So the facial movements are also going to take some time. So for you, it's like I gave him an exciting news and there was no response at all, there was no expression. That's what is called as mask-like faces. Okay, so we now know about the tremors, we know about the bradykinesia, and we know about the rigidity and the clinical manifestations arising out of that. This is one characteristic demonstration of the camptocormia, right? You can see the bent spine, such a severe deformity like appearance here. It is there even when patient is sitting, but the moment he lies down, it disappears. So this is what we call as camptocormia, right? We'll be reaching there. Yeah, we'll be reaching there. Okay. So these are the clinical features. So gait we have already discussed. Okay. Now coming to one more manifestation, which is called as postural instability test. So patients of Parkinson's disease, and in fact most of the other atypical also might have postural instability. So we have to test for it. So what do? We do a pull test. So if you have a patient here, right, as an examiner, you stand behind the patient and you pull himself towards you. Right? And as you pull, the normal person like you or me, if I pull you towards me, you will be able to regain your posture before you take 3 steps back. These patients will not be able to do that. Either they fall before that, or they will take a lot more steps before they gain the composure or the posture back. Okay? That is what is called as pull test. What to remember? It is the 3 steps. The norm is regaining the posture within 3 steps. In these patients, it will take more than 3 steps to become stable, or they will fall off. Ideally, we should not allow them to fall off. So we should be standing at not more than 3 steps away distance from them when you do this pull test. Okay, so that you should not let them fall, because they are vulnerable to fall. But if they are showing a tendency to fall, or if they're taking more than 3 steps to correct themselves, that suggests that they have postural instability, which is one more manifestation of your Parkinson's disease. Okay, so having said that, now let us talk about those non-motor features of Parkinson's disease. So whatever we discussed now, the bradykinesia, rigidity and tremors, these are classical motor features. What are the non-motor features we see? The non-motor features are seen in a reasonable number of patients, and I have already told you anosmia is an early manifestation. It can occur many years before patient has developed the tremors, right? Because the earliest sign of degeneration is in the anterior olfactory nucleus and locus coeruleus. So your autonomic dysfunction and anosmia are 2 non-motor features which can occur much before the motor features become evident. Okay, I think this point I've already told you. The autonomic nervous system dysfunction usually leads to constipation in patients with Parkinson's disease. Usually it leads to diarrhea in patients with the diabetes mellitus, right? Okay. Then orthostatic hypotension. One of the important reasons apart from the postural instability for falls is orthostatic hypotension. Why are they developing orthostatic hypotension? Again, because of autonomic nervous system dysfunction, right? Dysfunction. Okay, so these are 3 important non-motor features you should remember. Apart from that, they are prone to develop depression and some milder degree of anhedonia, and sometimes they can have even major depression. Okay, and the dementia, as I've already told you, is a late manifestation. It takes more than 10 years from the onset of motor features. So after that, they start showing the evidence of dementia. It's seen in around 20% of the patients. Not all patients of Parkinson's disease eventually develop dementia. In around 20% you will see. But when they develop dementia, first is they develop motor manifestations like the bradykinesia, rigidity and tremor features, and later they start developing the dementia. Clear? Okay. Now here I am also showing you something called as REM sleep disorder. It's also called as REM behavior disorder. Guys, am I live? Did we lose connection for some time? Just give me a thumbs up or some indication if we had lost connection, or am I live? I'm not sure because my screen blanked out for us for some time. Am I live? Okay, fair. So let me continue what we were talking about. So we were talking about this REM sleep disorder, or also called as REM behavioral disorder. REM behavioral disorder. So what is this REM, and is it specific to Parkinson's disease? Okay. So far what we have understood with respect to the tone is there is rigidity. The tone in patients with Parkinson's disease is increased. Okay. Now, all of us sleep, all of us do get good dreams, right? So what makes us not to enact our dreams during sleep? Brain is thinking, brain is probably in its own world. There are some thought process happening, there are dreams happening during the REM sleep. But physically we don't bring out those actions, right? If you are bashing your girlfriend next to you in your dreams, you are physically not doing it because something is stopping. That what is stopping is not your motor cortex activity, it is the tone. So normally during sleep the tone is significantly lost, so we are in hypotonic state. So whatever the brain is thinking is not put into action because of the lack of the tone of the muscles. So in patients with Parkinson's disease there is increased tone, right? There is this hypotonia. So this action. So if you're a patient with Parkinson's disease and you're sleeping, during your REM sleep you might start acting out your dreams. So if you're a cop and if you're bashing a criminal, then you will actually be doing those hand movements, because hypotonia, which restricts your hand movement, is not there. There is sufficient tone for us to execute those motions. That is what is called as REM behavioral disorder. So enactment of dreams. This is not specific to Parkinson's disease. We see this also in other conditions where we have alpha-synuclein defect. So our Parkinson's disease is one of the alpha-synucleopathies, right? We call them as alpha-synucleopathies. What are the other examples for alpha-synucleopathies where you might see REM behavioral disorder? So REM behavioral disorder is characteristic of alpha-synucleopathies. Where else we see? We see them in patients with diffuse Lewy body dementia, which is also one of the alpha-synucleopathy. And you will also see them in patients with multisystem atrophy, right? So these are your alpha-synucleopathies where you might see patients. Okay, so that completes the clinical features of Parkinson's disease. Now before we move on, this is one table I want you to remember from the sake of example. I mean, questions in terms of which of the following is or is not alpha-synucleopathy, or which of the following is not a tauopathy, or which of the following is a tauopathy. So you should know the degenerative disorders which are considered as alpha-synucleopathy. That includes your Parkinson's disease, dementia with Lewy bodies, and MSA. And as I've already told you, this REM behavioral disorder is very characteristic of alpha-synucleopathies. Enactment of dreams, it's very characteristic of alpha-synucleopathies. So what is the abnormality here? There is a abnormal alpha-synuclein, right? And in tauopathies there is abnormal accumulation of tau protein, either hyperphosphorylated or hypophosphorylated tau proteins. So examples for that are your progressive supranuclear palsy, corticobasal degeneration, frontotemporal dementia, and Alzheimer's disease. Alzheimer's disease is an example for both your tauopathies as well as amyloidosis. Okay. There was a question about Mayer's enzyme. Yeah, that is something which is not very specific, so not routinely described per se. Yeah, when you do a repeated glabellar tap, patients will continue to blink. Right? Normally that blink arrest, but these patients will continue to blink. That is what is called as the Mayer's enzyme. Yeah, it is considered as an early sign of Parkinson's disease, but not very specific. You can see in various other, in fact, almost all the disorders where you see some degree of neurodegeneration, you might see Mayer's enzyme. Right? It's not specific. But this REM behavioral disorder or some other things we spoke about, they're relatively specific. Okay, so having said that, now let us look at the next set of disorders so that we understand the differences between these. Yeah, before I move on, this is one more slide I want you to remember. These are frequently asked one-liner MCQs. What is the most common sensory abnormality in patients with Parkinson's disease? That is anosmia. We have discussed this multiple times by now. Right? The earliest manifestation, what is the site of neurodegeneration? So that is the most common sensory abnormality. What is the most common urinary abnormality? It is urgency. Urgency is the most common urinary abnormality. What is the most common GI manifestation of Parkinson's disease? It is constipation, not diarrhea. So normally when we talk about autonomic disturbance, generally diarrhea comes to our mind first, but we have to keep this in mind. Constipation is the earliest. Okay. What is the cognitive dysfunction? Bradyphrenia. What is bradyphrenia? Slowness of thought. Just like how we have slowness of movement, there is a slowness of thought process. And what is the common autonomic disturbance? It is postural hypotension. If they ask you what is the earliest evidence of autonomic nervous system dysfunction in Parkinson's disease, that is usually erectile dysfunction, ED. Okay, so that completes the important MCQs from the clinical aspects. Now coming to diagnosis, we will discuss the diagnosis now, and in the next session we will take up the pharmacological management. Okay, so how do you diagnose? Do we need an imaging for the diagnosis of Parkinson's disease? Do we need imaging for the diagnosis of Parkinson's disease? Do we need imaging? Do we need MRI or CT or anything? Or is it only clinical, or do we need brain biopsy? Do we need brain biopsy? The answer is no. It is purely clinical. The diagnosis is clinical. Before we go to the diagnosis, there are few basic revision points we should know. So in patients with Parkinson's, what are we seeing? We are seeing bradykinesia, plus we are seeing rigidity, plus we are seeing tremors, right? And we should know some basic points about tremors. Tremor 4 to 6 hertz, characteristically rest tremor, right? And asymmetry. Asymmetry is important point I want you to remember here. Asymmetry, right? Okay. And then this asymmetry is one point which I particularly want you to remember, because if you see that some patient present with similar features, like there is bradykinesia, there is rigidity, and there are tremors, but it is symmetrical, it is unlikely to be Parkinson's disease. Okay. Then the second point I want you to note is with respect to the overall picture, the rigidity. Yeah. With respect to rigidity, the rigidity is involving both your axial plus extraaxial muscles, and it is more affecting your anterior axial muscles in comparison to posterior axial muscles. Okay, so this is the basic thing we need to know before we discuss the diagnosis. So diagnosis, as I've told, it is clinical, and we follow, there are two criteria for the diagnosis. One is your UKPDS, United Kingdom Parkinson's Disease Society brain bank criteria for diagnosis of Parkinson's disease. The second one is Movement Disorders Society Parkinson's disease diagnostic criteria. Okay, so we have these two criteria, UKPDS brain bank criteria and the MDS, Movement Disorder Society Parkinson's disease diagnostic criteria. What we follow today in India is our MDS, because this is more latest, and studies have shown that this is more sensitive and more specific for the diagnosis of Parkinson's disease in comparison to UKPDS. UKPDS is older one, right, and it is less sensitive. It is less sensitive and also less specific. So this is the one that we follow. But some of your older textbooks might mention your brain bank criteria, so you have to remember that we have moved on from that and we are following the MDS, which is there from 2015 now. Okay, so let us look at what this criteria says. The MDS criteria basically has a bare minimum essential features that patient should have before you think of the diagnosis of Parkinson's disease, and then certain additional features. What is the minimum we need? The minimum we need is bradykinesia. Bradykinesia is a must. If there is no bradykinesia and patient has rigidity and tremors, no, it is not Parkinson's disease. Right? Is that clear? Bradykinesia is a must. Plus, between rigidity and tremor, patient should have one of them. Right? Bradykinesia plus, apart from bradykinesia, patient should have either rigidity or tremor. If both are there, well and good. No one is stopping you from diagnosis. Right? Either your rigidity or tremor. So bradykinesia is a must. So why I am repeating again this? They might ask you this question: what is the absolute essential criteria for the diagnosis of Parkinson's disease according to the MDS? Bradykinesia is the must. Once you have bradykinesia, if you have bradykinesia plus rigidity, okay, that satisfies the situation. Or if you have bradykinesia plus tremor, that satisfies the situation. So the rigidity and tremor are dispensable, but your bradykinesia is an indispensable feature, right? Okay, once you have these criteria met, bradykinesia plus one of these two are there, either rigidity or tremor, then it is possible that it is a case of Parkinson's disease. So for further diagnosis, we have to look at absolute exclusion criteria, right? None of these should be present. None of the absolute exclusion criteria should be present. None of these present. So what do I mean by that? Right. If you have cerebellar sign, now where do we see patients with bradykinesia, with rigidity, with cerebellar sign? Probably multisystem atrophy, the cerebellar variant, MSA-C, right? Then if patient has supranuclear palsy, like you have bradykinesia plus rigidity plus supranuclear palsy, where we see them? We see them in patients with progressive supranuclear palsy, right? If you have already been having a established diagnosis of a behavioral variant of frontotemporal dementia, not in favor of Parkinson's disease, then Parkinson's disease restricted to lower limbs for more than 3 years. I think I've already told this point. It is an upper limb predominant motor dysfunction that we see in comparison to lower limb. So upper limb involvement has to occur eventually, even if it is to start with lower limb. Most cases it is upper limb that where you will be seeing the tremors. So even after 3 years of having abnormality of the lower limb motor features, you still don't have upper limb involvement. That is not seen, or that's not typical of the patient of Parkinson's disease. So you should start thinking of other possible diagnoses in that case. Okay, then treatment with anti-dopaminergic with dopamine depleting agent. So if you have been treated with a dopamine depleting agent, some psychiatric medications, then first thing that should come to your mind is drug-induced Parkinsonism. So that should eliminate the possibility of Parkinson's disease first. When you rule out drug-induced, maybe later you can think of, right? So that is also one of the absolute exclusion criteria. Then another important feature of Parkinson's disease is great, at least in the initial few years, there is excellent response to levodopa. Excellent response to levodopa. So if there is an absence of response to levodopa, that again favors the diagnosis something else than the Parkinson's disease. Okay. Then the cortical sensory loss. So only sensory thing we see in patients with Parkinson's disease is your anosmia. If the cortical sensations like your tactile localization and your 2-point discrimination, which are the higher perception of sensations based on the primary input that you get from the basic sensations like your touch, pressure and pain. So that is done by your sensory cortex. So if that is involved, again it is more suggestive of certain dementia and the diffuse neurodegenerative disorders rather than Parkinson's disease. So that would also go against it. Okay. Then okay, this functional imaging we will discuss later. We will be taking up a image based session where we will be discussing how do you distinguish between the drug induced Parkinsonism and your what we call as Parkinson's disease from the imaging perspective. Okay, so these are all absolute exclusion criteria. None of these should be present. If any one is present, you cannot diagnose the case as your Parkinson's disease. Is that clear? Okay. Then we also have something called as red flag signs. So the point is these are essential bradykinesia plus rigidity and tremor and absence of exclusion criteria. Okay. The red flag signs are something which are not typical of Parkinson's disease, but they're acceptable. Like just because you have 1 or 2 red flag signs, that should not rule out the diagnosis of Parkinson's disease, but still they are not very certain or not very typical of. What are those? Rapid deterioration of gait. So in patients with Parkinson's disease, the gait deterioration is very slow, like it will take many years after the motor features are evident. Where we see rapid deterioration of gait, probably progressive supranuclear palsy or your multisystem atrophy with the cerebellar variant, where the gait deterioration is very rapid. So here it is slow. So it will take many years, not within few months or few years of the onset of motor features. That is against the diagnosis, but that is not sufficient enough to exclude the diagnosis. Okay. Then absence of motor symptom progression over 5 years. So Parkinson's, this is a progressive neurodegenerative condition. So if you have some motor manifestations, but they're not progressing, that means like you had one limb tremor appearing, the other limb slightly got affected and it is halted at that point of time. Again, not typical of the Parkinsonism. You might see such presentation when you have a vascular insult causing the Parkinsonism. You have some stroke, it caused the Parkinsonism, but there are no more strokes occurring, then you will not have this progression of these motor features. So at the end of 5 years, if there is no progression of the motor features, again, it is not very typical of Parkinson's disease. Similarly, involvement of bulbar muscles early or respiratory dysfunction, all of these are not typical, right? Very severe autonomic feature failure, that is also not very typical. Autonomic failure is known to occur, but early, very severe is not a feature. Again, early recurrent falls, I should think of PSP or maybe MSA. See where you will see. It's again, as I told, it is a late manifestation. Then, okay, what else we should be talking about? Yeah, presence of pyramidal tract sign, which is not characteristic, right? So it is only affecting the dopaminergic neurons. It should not be affecting the pyramidal tract. So if you are having hemiparesis or some other focal neurological deficits, not very typical of Parkinson's disease, right? Then the last point is particularly important. I had been stressing on this. So the symmetry is not the rule. Asymmetry is the rule in patient with Parkinson's disease. So here, if you are seeing there is a symmetry at the time of presentation or a well-established symmetry at any point of time in the disease course, that should be an essential red flag sign, not typical of Parkinson's disease. But presence of any of these, does it rule out the diagnosis? No. You might have 1 or 2 red flag signs. It is acceptable, but it should be counterbalanced by equal number of supportive criteria. So we have the third table here, which is about supportive criteria. What are those supportive criteria? So for example, you have 1 or 2 red flag signs, like you have a patient with rapid deterioration of gait, and then he has a little bit of symmetry at the time of presentation. So there are 2 red flag signs, fairly acceptable, provided there are 2 supportive criteria also present. So what are the supportive criteria? A very clear and a dramatic positive response to dopaminergic therapy, right? So if patient is showing all these features, are showing characteristic improvement after the levodopa was given to patient, then it is one important supportive criteria, because all other atypical Parkinsonism conditions do not respond that well to levodopa. Parkinson's disease responds much more better than the other atypical conditions. So that favors the diagnosis of Parkinson's disease. Okay. The second thing is levodopa induced dyskinesia. In other words, you can say dystonia. So to start with, the abnormality was the dopaminergic neurons are hypoactive. Right? You give a drug. If the patient starts showing a good response, that is a positive sign. If he shows a response which is beyond our expectation, bradykinesia to dyskinesia, right? So there was bradykinesia, the normokinesia or eukinesia established once you gave the drug, good. Furthermore, like patient started developing dyskinesia or dystonia. Well, that is also a good sign. That means the patient is like going to respond very well to the dopaminergics. So that is also taken as a good sign or a supportive criteria. Okay. Then documentation of a resting tremor of a limb. Obviously, we know that the resting tremor is characteristic. Then a positive diagnostic test of an olfactory loss. So we had been discussing this anosmia, right? So if there is a test to prove that, well, it is acceptable as a supportive criteria. Or the evidence of cardiac sympathetic denervation, autonomic nervous system dysfunction of the heart on a scintigraphy. These are all considered as supportive criteria. So what we need bradykinesia for sure. Plus either rigidity or rest tremor. That is the basic thing. Once you have a bradykinesia with rigidity or rest tremor or both, then you look at absolute exclusion criteria. None of these exclusion criteria should be present. The easiest way to remember the exclusion criteria is all of these, whatever I have discussed, are about the manifestations of atypical Parkinson's disease or plus syndrome. Cerebellar sign, MSAC, supranuclear gaze palsy, progressive supranuclear palsy. So most of these are manifestations of the plus syndromes or atypical Parkinsonism. None of them should be there, right? Then we look at the red flag signs. 1 or 2 of the red flag signs are acceptable provided patient also has equal number of supportive criteria. If no red flag signs, then we don't need to look at supportive criteria, right? Here only, once you exclude the exclusion criteria, the diagnosis is established. But if you encounter one or two red flag signs, then it should be countered by equal number of supportive criteria. So that the end of that, you will have a clinical diagnosis of Parkinson's disease. This is the MDS. Okay. We also have this UKPDS diagnostic criteria. UKPDS diagnostic criteria, which is relatively older, and the recent studies show that it is MDS which is superior in comparison to UKPDS. So the older studies all suggested that the UKPDS was much superior in comparison to their diagnostic accuracy, but the latest studies show it is MDS which is more reliable, and it is much more convenient to practice on a routine day. So mostly we follow the MDS as of now. Okay, now coming to this UKPDS, this is also in a very similar line. What it says is we need bradykinesia plus at least one of the following, either muscular rigidity, rest tremor, or postural instability. Okay, why it starts losing the sensitivity in the modern days is because it talks about postural instability. So if you include rigidity and postural instability, right, then your plus syndromes can be covered here. If you include the postural instability, so because there are various other manifestations, various causes for postural instability beyond the movement disorders, which could be one reason why the dilution of the specificity occurs, right? Okay, so this is initial bradykinesia plus you need one of the three things that are mentioned here. So we had two things here, the rigidity or the rest tremor. We have added the postural instability, so we need one of the three plus bradykinesia. Again, here also bradykinesia is something that is must, right? Bradykinesia is must. This is a potential MCQ point. Then we have supportive criteria, which are again related to the things that we discussed so far: the unilaterality at onset, rest tremor, progression, asymmetry. These points I've already discussed, right? Asymmetry is the rule. Most cases onset unilateral, then even if it is bilateral, asymmetry is the rule. Good response to levodopa therapy, right? All these are supportive criteria. Okay, so after supportive criteria, you should rule out certain exclusion criteria. What are the exclusion criteria? This is where again we start seeing the impact or how it starts diluting the specificity or sensitivity. Repeated strokes. If you have history of repeated strokes, it doesn't mean that all strokes are, because you have history of strokes, which is very common at 60 or 70 years of age nowadays, right? Multiple lacunar infarcts are very common. All of them need not be related to Parkinson's disease. So that kind of dilutes their repeated strokes. Okay, but these are exclusion criteria: repeated stroke, repeated head injury, encephalitis. Okay, oculogyric crisis acceptable, use of neuroleptic agents, unilateral features after 3 years, means even after 3 years patient has the tremors or motor features lateralized and not progressed to bilateral, or having supranuclear gaze palsy. So you will notice that there are a lot of similarities between the MDS and UKPDS, but because most recent studies support use of MDS over UKPDS, we follow that as of now. Okay, so that is about the diagnosis. So I asked one question in the very beginning. The question was, Harrison medicine symmetry you might see mostly in patients with drug-induced Parkinson's disease, or you might see if tremor occurs in other atypical, which is rare, but if it occurs, you might see symmetry there. A classical example of a symmetric tremors is the drug-induced Parkinson's. So if you have a akinetic rigid syndrome with symmetry in terms of tremors, it is most likely the drug-induced that I would think of first. Okay, yeah, apathy, Alzheimer's disease, agreed. Okay, so that is done. Now, this is one thing which can be an image-based question for you. I have already told you the imaging is not required, but if you do it, this sign is very specific. This is quite specific for the diagnosis of Parkinson's disease. It is not required because we are taking into account various clinical features, supportive and the exclusive criteria to come out with the diagnosis. But if at all you happen to do the neuroimaging, you might see something like this. This is what you're seeing in the first image is of a patient with normalcy. So if you look at, this is the substantia nigra that we're looking at, and it shows two finger-like projections, right? You can appreciate here. So this is often looks like the tail of a bird, right? So this is called as swallow tail sign. So swallow tail sign is seen in normal people. It is a sign of normalcy, right? So if you do the imaging of a normal person, you will see substantia nigra look like this. In patients with Parkinson's disease, there is a degeneration of the substantia nigra, right? So what we see is this bifid appearance is lost. So you can see in the second image, you don't clearly see a bifid appearance, right? That bifid appearance is lost, and even you might see that the tail is stunted. So the tail, the swallowtail was longer here, right? So that gets also kind of stunted. This is called as loss of swallowtail sign. So this loss of swallowtail sign is specific for Parkinson's disease. This is specific for Parkinson's disease, right? Is that clear? It is not required for the diagnosis, but if you do it, you might see this. They might give you an image and ask you, right? Okay. Now what we are seeing here is called as the DAT scan. DAT scan stands for dopamine transporter scan. What is the use of this? This scan, again, I've already told you diagnosis is clinical. So why are we doing this scan? This scan may be particularly useful when you're confused between Parkinson's disease and drug-induced Parkinsonism. Drug-induced Parkinsonism. Why this confusion there? Drug-induced Parkinsonism. Why this confusion? Well, in case of drug-induced Parkinsonism, as such we're expecting a tremor which is usually symmetrical. But if at all you have a patient with Parkinson's disease where the symmetry is very subtle, asymmetry is very subtle and may be difficult to appreciate for someone who is not well trained or who has not seen many patients with Parkinson's disease, the tremor might look symmetrical in such situations, and you might get confused whether it is drug induced or a Parkinson's disease. And it is also common because elderly will be exposed to multiple drugs. So nowadays you will see elderly patients with a polypharmacy, a long list of prescriptions, and you will see some case reports of this drug causing that or that drug causing this kind of presentation. So that can arise confusion. So how do we solve that? We can solve that by doing this DAT scan. So what is DAT scan? So in DAT scan, we are trying to localize the dopamine transporter. We're trying to localize the dopamine transporter. So where is the dopamine transporter present? The dopamine transporter is present mainly in the presynaptic terminals, right? So you have this synapse and your postsynaptic neurons. So dopamine is stored in secretory vesicles from where it is released, and you have these dopamine receptors in the postsynaptic terminal, right? So this dopamine acts there. So dopamine is here and you have your dopa receptors here, right? Now this dopamine transporter is required for the release of this dopamine from the presynaptic terminal. So the dopamine transporter is localized to the presynaptic neurons. Now if there is a disease that affects the presynaptic neurons, right, the dopamine transporter will be lost and you will have a dopamine transporter scan which is going to be abnormal. If it is a disease which is affecting the postsynaptic neurons like the dopamine receptors, then the dopamine transporter scan will not be affected because the transporter is localized to the presynaptic neurons. So in case of Parkinson's disease, what is the abnormality? The abnormality is the presynaptic neurons are degenerated. So in case of drug-induced Parkinsonism, in most cases the abnormality is there is blockade of dopamine receptors, right? So these drugs are blocking the dopamine receptors. That's why we are seeing the Parkinsonism, the drug-induced Parkinsonism. So in which patients the scan is going to be normal and in which patient the scan is going to be abnormal? In which patient the scan, right? So the DAT scan is going to be normal in patients with normalcy, right? If you're a normal person, it will be normal. It will be normal in patients with drug-induced Parkinsonism. And if at all you are confused between the essential tremor and the tremor of Parkinson's disease, it's going to be normal in patients with essential tremor. So it will be abnormal in patients with Parkinson's disease. So this is one test that helps us to distinguish between the Parkinson's disease versus essential tremor on imaging. This is one test that helps us to distinguish between Parkinson's disease and drug-induced Parkinsonism, right? Because the drug-induced Parkinsonism is affecting the postsynaptic neurons and the Parkinson's disease is affecting the presynaptic neurons. So because the dopamine transporter is located to the presynaptic neurons, you will have an abnormal dopamine transporter scan. So this is how normal scan would look like. You can look and scan, you can look we were discussing about this loss of swallowtail sign, right? The similar distribution of failed uptake, right? So the tail is stunted or blunted or shortened, right? So this is abnormal scan. You can correlate now from the previous image. Right? So we're looking at the substantia nigra, and there is reduced uptake of the tracer here. So this is a abnormal scan. So abnormal scan is seen in patients with Parkinson's disease. It will be normal in drug induced. It will be normal in drug induced because in drug induced the postsynaptic dopaminergic neurons are affected. It is like what is the drug induced? Most of the drugs which cause Parkinson's disease, they block the dopamine receptors, right? So you block the dopamine receptors, dopamine is coming from the presynaptic neurons, it is not able to work on the postsynaptic neurons, and so you are seeing the normal scan there, because the dopamine transporter is required for transport of the dopamine from the secretory vesicles to the release site, so that it is released into the synapse. So the transporter is localized to the presynaptic neurons, right? So if the transporter is lost, that means there is a defect of the presynaptic neuron, which is typical of Parkinson's disease. So you will see abnormal scan in patients with Parkinson's disease. So in drug induced, it is going to be normal. In a normal person, it is going to be normal. In patients with essential tremor, it is going to be normal, right? Okay, so that completes the session for today, guys. I think in the tomorrow session, let me take up the management of Parkinson's disease and discuss the other tremors, like progressive supranuclear palsy is one thing I want to discuss, and your MSA and P and dementia with Lewy bodies. These are bare minimum things that we need to be aware. So we'll take up that tomorrow. So thank you all for connecting, and see you tomorrow roughly at the same time, I believe. Thank you all. See you tomorrow.